Peter Ashenden. I'm the Director of Consumer Affairs at the National Office of Optum Behavioral Health Solutions. This is my contact information. I'm here to help you however I can. It's an honor to be able to take and to be able to offer these webinars so you know how important they've been to our peer supporters throughout the country. The comments from you are just unbelievable. So I thank you very much for this. I'm glad that we're able to put collaboration together with the International Association of Peer Supporters and make this possible for you because these are great learning experiences. Today we have a very, very distinguished guest. His name is Larry Davidson. Larry is the Professor and Director of Programs for Recovery and Community Health at Yale University, a very prestigious school in the School of Medicine. I've had the opportunity of meeting Larry and interacting with Larry on many, many different occasions. He is a person who understands recovery. He's a person who is open about his own lived experience and has written about it. And I frankly think he's one of the brightest people I've ever met. He brings forward his points in a wonderful way. He's just so bright and so committed and so going to take and change how we deliver services. He's that committed to it. So we're very, very fortunate to have him. He's going to be going over the history of the peer support movement. So at this point, I'm going to take and turn it over to Larry.
Thank you, Peter. I'm blushing. Can't see my face, but it's red. I thank you all for joining us today. This is a topic near and dear to my heart, and I'm sure to yours. And I was very pleased to have been invited to come and talk with you about it. I think I was invited because I understand that peer support is actually, even though it's a recent phenomenon, and if you could put up that first slide, Peter, even though it's a recent phenomenon that started in the late 1980s, it's actually it has a fairly illustrious and much longer history, which is what I'll be sharing with you in a few minutes. But just to be clear, I am going to be talking about peer support, which emerged in the late 1980s as a result of the mental health consumer survivor ex-patient movement. This is not a history about that movement. I saw already there are some luminaries from that movement who have signed into this webinar, including Peter himself. And I would not presume to talk about the history of the consumer survivor ex-patient movement. I'll only be talking about peer support, which also means I won't be talking about mutual support. And mutual support preceded peer support in things like Recovery Inc. and GROW, which has become a global mutual support group. So there have been mutual support groups for a long time. They are not the same as peer support. By peer support, and I offer you here a definition, I mean people who have experienced a mental illness or psychiatric distress, emotional distress, whatever language you want to use for what I have to call a mental illness at the Yale Medical School, who are either in or have achieved some degree of recovery. In their role as peer supporters, they use these personal experiences of stress, adversity, and recovery, along with relevant training and supervision, to facilitate, guide, and mentor another person's recovery journey by instilling hope, role modeling recovery, and supporting people in their own efforts to reclaim meaningful and self-determined lives in the communities of their choice. Now I know as peer support has rapidly expanded around the globe, many people mean many different things by peer support, which is why I offer this definition of how I think about peer support. And I'm going to be talking some about the different permutations and some of the dangers of that in a few minutes, but I wanted to at least start with a common understanding. So next slide, please. Peer support is one kind of helping or healing relationship among several, and this graphic has been useful to some people to understand where it fits. So if you think of a continuum of helping relationships, which at one end is a one-directional relationship like psychotherapy, where there's an expert and a participant, or case management, in which there's a person who is supposedly managing you as a case. And at the other end, there are friendships, naturally occurring friendships. Peer support is somewhat transactional relationship in which one person is paid, the other person is not. But in many other ways, it's meant to be a reciprocal or mutual relationship, and that's one of the tensions that we continue to face in the work that you do, is to what degree is it a mutual relationship, and to what degree is it a more formal relationship in which one person is paid to be supporting another. And historically, there have been at least two kinds of peers as provider services. At first, in the late 80s, early 90s, many peers, the first peers who were hired to provide conventional services like case management assistant or residential support or something like that. So these were people in recovery who were hired, but they were hired to fill what were already existing positions that had been hired by non-peers, or they were hired into new positions, but ones that were still understood to be really professional provider or paraprofessional provider relationships, like a case management aid. As we'll see in a few minutes, the research on that kind of peer work was mainly feasibility studies to show that it was possible for people to do that, and that may sound ridiculous or absurd right now, but I can tell you, having been doing this work since the late 1980s, when we first started talking about hiring people in recovery to provide services of any kind, people thought we were not in our right minds, let's put it that way. They didn't realize yet that people could recover. So the first generation of studies done in the early 90s just showed that it was feasible to do this and that people were not hurt by it, because there were a lot of concerns about how peers might be harmful to people. They might say the wrong things, as I was once told. The second generation was peers being hired into roles that are really for peers, in which people use their lived experience and their street smarts to role model, instill hope, and do all those kind of things that we'll talk about. This research has been growing. It's still in its early stages, but the findings have been very promising, and we'll cover that in a few minutes. But the next slide, please. Before I get back to that, and just to note that while it started in the late 1980s, there has been an unprecedented expansion of the workforce. Over 30 states now provide Medicaid-funded peer support. The VA alone has hired over 1,200 peer specialists. Some of us are involved in drafting an international charter because peer support has become a global phenomenon, and at this point there are over 15 countries from all 6 continents. The only Antarctica is not represented in this charter work group. So 15 countries from 6 continents have been developing an international charter, which we will make sure that INAPS, well, Steve Harrington is one of the people on this work group, so we'll make sure that INAPS has access to that. The rapid growth has led to some concerns about co-optation and loss of the integrity of peer support, and that's one of the things I'll come back to. Next slide. But I think I was really asked to talk to you about this because when you look back at the history of psychiatry, there were earlier precursors to peer support. And I was really quite astounded to find out that the first documented instance of peer support was in 1793 in Paris, at least as far as I can find. Many of you will know about the moral treatment era. That was when Philippe Pinel in France and the Tukes in England and other people around the world decided, as part of the Enlightenment, that people with mental illnesses were still people too and should be treated with dignity and respect first and foremost. So there was a reform period of changing what had become really horrible institutions. The asylums of the 18th century were really awful places where people were caged and chained to the walls and beaten and abused and neglected and all kinds of horrible things, which I know resurfaced later, 100 years or so later. But this was the first era of reform, and Philippe Pinel has largely been claimed for instituting moral treatment and being the father of what we now call the branch of medicine called psychiatry. But when you go back and look at the historical records, Pinel himself wrote about the fact that he was not the one to unchain the inmates of the BAPTISTE or the Salpêtrière, which were French asylums, but it was actually Jean-Baptiste Poussin, who was the governor of BAPTISTE when Pinel arrives, who had unchained the inmates and whose main strategy for humanizing the asylums was to hire recovered patients to be the staff. Next slide, please. In his own treatise on mental alienation. Pinnell wrote about Poussin's strategy of hiring recovered patients to staff the wards and I'm going to read to you what he wrote. Just bear with me for the language. This is from the 1790s. In lunatic hospitals, as in despotic governments, it is no doubt possible to maintain, by unlimited confinement and barbarous treatment, the appearance of order and loyalty. The stillness of the grave and the silence of death, however, are not to be expected in a residence consecrated for the reception of madmen. A degree of liberty, sufficient to maintain order, dictated not by weak but enlightened humanity, and calculated to spread a few charms over the unhappy existence of maniacs, contributes in most instances to diminish the violence of the symptoms and in some to remove the complaint altogether. So he's saying basically that the methods that had been used to keep people quiet were not helpful, and that people needed freedom and respect in order to regain their minds. Next slide. Such was the system which the governor of the Bicentre endeavored to establish on his entrance upon the duties of his office. Cruel treatment of every description and in all departments of the institution was unequivocally prescribed. No man was allowed to strike a maniac even in his own defense. No concessions, however humble, nor complaints nor threats were allowed to interfere with the observance of this law. The guilty was instantly dismissed from the service. So Poussin came in, said we're not going to abuse and neglect people. We're going to treat them with dignity and respect, and if you don't do that, you'll be fired. And then Pinnell continues, it might be supposed that to support a system of management so exceedingly rigorous required no little sagacity and firmness. Next slide. The method which he adopted for this purpose, though, was simple, and I can vouch my own experience for its successes. His servants were generally chosen from among the convalescents, among those people who were recovering, who were allured to this kind of employment by the prospect of little gain. Averse from active cruelty, from the recollection of what they had themselves experienced, disposed to those of humanity and kindness from the value which for the same reason they could not fail to attach to them, habituated to obedience and easy to be drilled into any tactics which the nature of the service might require, such men were peculiarly qualified for the situation. As that kind of life contributed to rescue them from the influence of sedentary habits, to dispel the gloom of solitary sadness, and to exercise their own faculties, its advantages to themselves are equally transparent and important. So basically what Pinnell is saying is Poussin hired people in recovery because they would be kind and treat other people with respect because they knew what it was like to be abused and neglected. And not only would they then promote the recovery of the people they were supporting, but it would enhance their own recovery as well. So it was a win-win situation. Next slide. So if you look at this famous painting of supposedly Dr. Pinnell at the Salpêtrière unshackling the female inmates, go ahead and hit the button a few times. You'll notice that it really wasn't Pinnell, it was Jean-Baptiste Poussin. And the person to his left, who was an orderly who was one of the staff of the asylum, was the first peer supporter. So it was Poussin and his staff of peer supporters who really humanized the asylum in Paris in the 1790s and ushered in the golden era of psychiatry, which was the moral treatment era. Now you can go to the next slide. We also know that Harry Stack Sullivan, who was one of the fathers of American psychiatry in the 1920s in Baltimore, himself had a number of psychotic episodes in his adolescence, became a psychiatrist, psychoanalyst, and started one of the first inpatient units for people with psychosis in the country at Shepherd Pratt Hospital. And his tactic was also to hire people who had recovered on his unit to become the staff to help other people recover as well. Next slide. There was a period in American psychiatry after Sullivan where the therapeutic community models, which was largely influenced by psychoanalysis. So these were therapeutic communities. This was before state hospitals became largely institutional and custodial institutions. This is what level systems and community meetings and all these things were first instituted. And somewhat unappreciated by history is the role that peers played in these therapeutic communities. peers in the therapeutic communities and the peers today is that they were not paid for their work because it was considered to be part of their own recovery. But the role modeling and mentoring that we provide now was being provided in an incipient form back then, and is to some degree continues to be provided in an unpaid way in clubhouses and some peer-run, well, not peer-run, but some clubhouses and other programs in which there is a continuation of a community model. Next slide. Going from peer support to peers who had tremendous influence on policy, Dorothea Dix, who was credited with starting the state hospital movement, which was meant to make moral treatment asylums accessible to people who did not have the resources to pay for private retreats, herself had had 2 psychotic episodes and had been treated in England in a very loving family setting, and she wanted to make that kind of family environment of safe support and structure available to other people who did not have the means. And she started the state hospital movement, so the idea that people should have access to quality, safe, dignified care was started by a person in recovery. And then Clifford Beers, who many of you will know had been treated at Connecticut Valley Hospital in Connecticut, started what is now called the mental, or what was then called the mental hygiene movement. Today it's called the community mental health movement. So the first person to really advocate for providing people access, all people access, regardless of means, to mental health care was herself a person in recovery. And the person who said, no, we don't need hospitals to do this, we can provide care for people in community settings, was himself a person in recovery. Next slide. Why do I mention this? Oh, I'm sorry. Just a couple of minutes on. There are parallel. No, go ahead. That was fun. I just forgot what we're going to. I just want to pull addiction recovery into this as well. So I've been talking so far about mental health. I understand that N.A.P.S also has people in addiction recovery, people in dual recovery. So I just wanted to mention that you'll find parallels to this in the addiction world as early as the 19th century. Next slide. And there are consistent examples of this throughout the history of addiction recovery. Most people are very familiar with Alcoholics Anonymous and all the 12-step derivatives. They were obviously founded by Bill W., who was a person in recovery. And these are forms of mutual support. Next slide. So summing up, it was not Pinnell who removed the shackles. It was Poussin, and Pinnell observed that and described Poussin's approach, which relied heavily on peer staff, hiring convalescent patients to staff his wards. Dorothea Dix's crusade to offer care to everyone, regardless of their means, was fueled by her own experiences of psychosis as well as her sense of social justice. Clifford Beers' advocacy to close hospitals and create community-based systems of care was based on his own experience, and recovery from addiction was catalyzed by Bill W., who had about 100 years of predecessors before him talking about the value of mutual support for recovery and addiction. Next slide. What is my point so far? My point is that lived experience, real-life experience, provides a crucially important and valuable source of evidence. Usually when we think of evidence, we're talking about randomized controlled trials. Now we're talking about life-based evidence. And this life-based evidence has provided the basis for very important policy changes for people in recovery from both mental illnesses and addictions. But what history suggests, and this is what the point I'm getting to, history suggests that these lessons learned from lived experience can then get separated from the experiences themselves and the people who had them and can be appropriated by others for various and sundry purposes. So if you look at a medical textbook, you don't see Poussin and the peer staff at the Bicetre. You see Philippe Pinnell, father of psychiatry. And when you hear about the community mental health movement, you typically hear about Eric Lindemann, who was a psychiatrist at Harvard, Mass Mental Health. You don't hear about Clifford Beers. So I want us to be clear that the system that we have was based on the ideas and inspiration of the recovery community, but that has had a tendency to be usurped for other purposes. And the point of saying this is, next slide. Go ahead. Vigilance, vigilance, vigilance. For those of you Harry Potter devotees, you will recall from book 4, motto for the students at Hogwarts was vigilance, constant vigilance. We need to be vigilant in protecting the insights that come from the recovery community and make sure that they are not lost in the process of transition. Next slide. But let's get back to history. So I mentioned that the first generation studies showed it was feasible. Second generation studies showed that peer staff were able to produce at least equivalent outcomes to non-peer staff in similar roles, and also was able to show increased effectiveness in engaging people into care and reducing hospital readmissions. But now we're on to a third generation of studies that are investigating all kinds of things in addition to those more hard traditional medical outcomes that are looking at things like hope and activation for self-care. And we're finding that peer support is very effective in these domains as well. Next slide. I'm gonna go through these quickly because we're already at 12:25. But our first study was a study of engaging people into care. Next slide. And we were able to show that peers functioning in a peer support role could increase the degree to which care was responsive to the people they were supporting. Next slide. Could improve people's social functioning. Next slide. Could decrease their use of drugs and alcohol, which we didn't expect because we didn't target that specifically, but we've seen this consistently over time, especially alcohol use decreases. Next slide. And their use of hospital and ER services decreases as their use of outpatient services increase. So as peers get more connected to peer supporters, they tend to make more use of traditional, conventional mental health services, hopefully in a more empowered, self-determined way. But if you push the button again, you'll see that when the peer support is removed, people go back to their old habits. So we've learned this about peer support. We shouldn't be surprised. We've learned over time that many of the interventions that we offer people with serious mental illnesses, like concerted community treatment, work as well as they're being offered to the person, but when they're taken away from the person, they tend to have more difficulty. I don't find this surprising because I've had glasses since I was in the 7th grade, and at no point did anyone come along and say, you've had your turn with your eyeglasses, you need to give them up, somebody else needs them. But we say that to people in recovery all the time, that they can have a job coach for 3 months, even though they might really benefit from having one for 3 years. And this is just one of the arguments about why a disability model is more useful, because you don't take people's wheelchairs away, and you shouldn't take people's peer supporters away. Next slide. We were able to show in a study in the early 2000s in Connecticut, which has remained one of the few states that doesn't have mandatory outpatient treatment or mandated outpatient treatment, we were able to show that deploying peer specialists to engage folks in care who had had a history of refusing or dropping out of outpatient services were able to engage them into services more effectively than non-peers. Next slide. And then there were a number of outcomes we were able to find in a randomized control trial of peers functioning both as facilitators of person-centered care planning and as community integration or community inclusion. But focused on community integration and community inclusion. And that people showed more satisfaction with their family life, with themselves, with their sense of belonging, social support. Something that's become increasingly important that Matt Shinman has shown in his wonderful research in the VA system is that people become more engaged in managing their illness or more engaged in what we call self-care. And that's a very important focus of the Affordable Care Act and current healthcare reform efforts, which we may or may not get time to talk about during this webinar. But it's going to be more important in the future. Next slide. And then more recently, we've done what we call recovery mentoring, and we've been able to show, next slide, and next slide, and next slide. All these slides are going to be available to folks who want to look into the details. Next slide, and next slide. So we've been able to show that having a peer mentor decreases drug use, increases hope, decreases depression, increases self-care. Again, that's a consistent so far about peer support in terms of the research done in the last 15 years is that having peer outreach workers can reduce readmissions by 42%, a day in the hospital 48%. This kind of work has also been done by Optum and other managed care companies in the private sector, showing similarly that you're able to reduce high-cost service utilization. Decreasing substance use and decreasing depression and increasing hopefulness have been consistent findings, as have engagement in care and activation for self-care, and increased sense of well-being, and an improvement in relationship with providers, which some people are surprised by because they see peer staff as somehow being critical of or undermining of clinical care, but in fact it's the opposite. And there is a very nice review done by Matt Shinman and his colleagues in a recent issue of Psych Services. Next slide. So, current situation. Peers have been hired into a variety of roles with a variety of names. They've been hired both outside and inside of mental health agencies. By outside, I mean in peer-run organizations. They've been hired into agencies with varying degrees of understanding and acceptance of the peer role. And if you're not aware of this, I would just take a second to say that peers can only be as effective in their role as an agency is prepared for supporting them and valuing them in that role. And you may have already had webinars on that topic, but I think it's an increasingly important topic as more and more peers get hired, that the agencies that hire them understand what they do and are prepared to support them in doing it. And so far, because transformation is still early in the process and most mental health agencies have not changed that much, tension is more the norm than not at this point. Tension, I mean, between the peer role and the expectations and understanding of the agencies into which peers have been hired when those are mental health agencies, not peer-run organizations. Next slide.
Before we go to the next slide, could I ask you a quick question we have from the audience? Would you be okay with that?
Yes.
Do you know of any research on the effectiveness of peer support in acute care inpatient settings?
Say that again, acute care.
Do you know of any research on the effectiveness of peer support in acute care / inpatient psychiatric settings?
Oh, no, I do not. The only place that has really even done much in terms of hiring peer staff for acute care inpatient settings is in the United Kingdom. And if you want to Google IMROC, IMROC, it's, I forget what it stands for, but basically it's the vehicle the National Health Service is using to transform their hospitals to a recovery orientation. You might find some descriptions of peers in those roles, but I'm not aware of any empirical data yet.
Thank you so much. And I will move us to the next slide, as well as deal with 3 problems at the same time.
Well, that's what peers are able to do, Peter. So
right, we know how to multitask, don't we, Larry?
Yeah. So I just wanted to spend a couple of minutes on some ways to tell the difference between when peer staff are functioning in role as peers and what are some warning signs, some early warning signs for when peer staff might be succumbing to institutional pressures and compromising that integrity. And these are my suggestions only. I'm certainly open to other people's, and I'm open to discussing and debating these. But these are some helpful tips, or I hope helpful. They're offered to be helpful tips. So do peer staff view service users as their peers? And I know that may sound obvious or silly to some people, but I've actually seen instances in which peer staff lose the sense that the people they're supposed to be supporting are their peers. Our peer staff encouraged to disclose their own recovery stories and to bring their life experiences with them to the table, both with the people they support, but also in team meetings or case conferences or in other settings. And again, I'm aware of instances in which peer staff have been hired and told that they cannot disclose their recovery stories because it violates boundaries. Is there clarity in roles, or do peer staff roles overlap with existing staff roles? Ann Beals, who's a wonderful peer leader in England, said that basically if what the person is doing they can do without having lived experience, then it's not a peer role. Next slide. Peer staff spend the majority of their time being asked to do things, solve problems, get people places, take care of things, or do they spend the majority of their time just listening and being with people? Do peer support staff have a champion in the senior leadership position who endorses and ensures the integrity of what they provide at the agency level? Without such a person, it's going to be very difficult to preserve your integrity. Are peer staff viewed as one element of a broader agency-wide transformation to a recovery orientation? I'm aware of systems in which they hired peer staff and now think that they're done with their transformation process. Transformation requires a significant amount of change. Agency system-wide, adding peers may help to point out where the other changes need to be, but it doesn't take care of making those changes itself. Next slide. Is inevitable discrimination addressed in the workplace? And maybe you've had a webinar on this also, but it would probably be worth having a webinar just focused on identifying and eliminating discrimination in the workplace. Is discrimination understood as discrimination? People talk about feeling stigmatized on the job, but that it might be better understood as, are there discriminatory practices in the agency where the person works? And are those understood to be discriminatory? Are peer staff trained and supervised for the roles they're being asked to perform, or are they just hired and said, okay, go to work? Are peer staff supervised by someone who understands the value of lived experience? We hope to get to a point where peer staff are supervised by peers, but a lot of agencies don't have that capacity yet and are having peers supervised by people who really know nothing about the value of life experience and what peers have to offer, and that's obviously not ideal. Are there opportunities for upward mobility? If you've been a peer staff member working with direct care for 4 to 5 years, can you become a supervisor of other peers? Next slide. And is there at least a tension between engaging people into the existing system of services and supports, which peers are often asked to do, and so that has gone so far as to be told that their job is to encourage attendance and adherence? There was an article written, I think it was about the Georgia work in Georgia from the Medicaid perspective, which talked about how peers are paid less and helpful in keeping people on their meds. Now, obviously, that's not something that peers were initially intended to do, and we can discuss whether that's even appropriate for them to do, but we don't want to see peers hired into systems which then use peers to continue the same coercive practices that were there before peers were introduced. So is there at least a tension between engaging people into an existing service system and advocating for that system to change? And that's what we hope peers will have as a transformative effect on agencies and systems of care to make them more responsive to the needs of the people they serve. And only one example of that is peers who are facilitating person-centered care planning, but there are lots of other ways in which peers can make services more responsive. Next slide. So peers are often in the position of having to educate or manage up in systems. Usually when someone's hired for a job, their supervisor or other higher-ups orient them to the roles and tasks they're to be performing. But in peer support, there often aren't people in such a position who understand that. So the leaders don't really know much about what the person's being hired for and can't really do the supervision. And the training that peer staff receives typically has not addressed how to handle this situation, this unfortunately but inevitable situation in which they have to manage up. And part of that is identifying the microaggressions or the instances of discrimination that occur, and unfortunately those often go unaddressed, which makes the work very difficult. Next slide. I just wanted to spend a couple of minutes on the future. There's looks like a lot of traffic in the chat box, so we should have some time for questions and discussions. But
yeah,
I think
I just want to leave a little time for Q&A because I can't keep up with all the questions here.
All right, then there's lots more slides I'm not going to get to, but again, people feel free to access the slides and read through them in their leisure. But I did want to spend at least a couple of minutes talking about the future. So we've talked about the past, we've talked about the current situation. In the Continuum continues to be implemented and unfold, there will be more and more of a focus on person-centered health homes, shared decision-making, and self-management, which is the medical term for taking care of yourself. And there will be a role, there is a role already, there will be an increasing role for what is called in the legislation, patient navigators, who are community members trained in strategies to connect people to care, help them overcome barriers to receiving care, and assisting them in various other ways through their course of treatment. Our hope is that in behavioral health, certainly that will become a very viable role for peer staff who, in addition to being navigators, can provide all of the other benefits of peer support. But we hope that that may also branch out into medicine in general. Next slide. Next slide. We don't need to go through what navigation involves. Next slide. Next slide. And this is where I was wanting to get to. Activation. This is a fancy scientific term for saying, are people engaged in the process of taking care of themselves? And what do people need to learn in order to take care of themselves? So how can people be prepared for their visit to their healthcare providers and feel empowered and educated to know what questions to ask and how to ask them to get answers to the questions they have? Can people identify and set their own health-related goals, which may plan specific action steps to achieve those goals? Do they exercise and do they eat well? Do they know how to take care of themselves on a daily basis, like sleep hygiene? Do they know how to get a good night's sleep? Could they use some help with problem solving in addition to the system navigation? Could they use support? All of us could use support. But people coping with or living with certain conditions receive support more specific to that challenge? And can people get that kind of support over time? And the answer to all of those questions is with the Affordable Care Act's implementation, should it continue to move ahead, these will become much more commonly offered in our broader healthcare system as well as within the behavioral health system. Next slide. Next slide. So this is probably a good place to stop. We're moving away from symptom management and falsely, unnecessarily accepting long-term disability. We're moving toward promoting recovery, social inclusion, and citizenship through the use of community-based supports, including peer-based supports. The Centers for Medicaid and Medicare and the private sector will follow behind them in shifting to a self-management or self-care approach to long-term health conditions, including behavioral health. I was actually involved in a CMS initiative to develop guidelines for self-management in behavioral health. So it's not just diabetes and hypertension, but it's schizophrenia, bipolar disorder. And who better to promote self-care than peers? I will end on that note and see what comments and questions you guys have.
Thanks so much. I really appreciate everything you've done. What a tremendous presentation. What I'm going to do is, okay, we are at the question point, but so, from Gail Bluebird, Delaware, very successful in hiring peers and inpatient. I also did a guidebook on peers working in inpatient settings, which would be glad to provide information on. Also, history of the movement not included. Humbug. Those were some comments from Gail. Gail, if you would take and get that literature over to Steve Harrington, he'll make sure that he gets it up on the website.
Gail, could you email that to me too, if you don't mind? And I probably before you joined, I said I wasn't going to do a history of the movement because I'm not in a position to do that. I'm going to just talk about peer support.
And let's see, I have, hold on, oh God, these questions, they're so fast. Lots and lots of great information. I'm in recovery to a new hire for a crisis respite unit in behavioral health. I'm a peer provider. How could I better my knowledge in gaining experience in this field? From Robert Rodriguez.
Well, hopefully, Robert, there's some training and supports available in your local community. If not, then there are resources available. RAP, somebody else already mentioned, Wellness Recovery Action Planning and intentional peer support are approaches that a lot of folks in the field have found very useful, and there are resources available on the web for those, and also courses that you can take if you were able to travel. But as a first step, I would certainly recommend looking into those.
From James, you didn't put it. You got to put everyone in the actual function. Would it be appropriate for peer specialists to use illness management and recovery when working with others? I have a problem with the term illness management. I would much rather see us use the term wellness management, but I'll certainly turn this over to you, Larry, for comments.
Well, I think there are better things that peer staff could be using. I think most people in the peer field would argue that wellness recovery action planning is more peer-driven and has been just as effective, or perhaps more effective, than illness management and recovery. And I agree that the language is not very useful, and the ways in which illness management and recovery, if a peer wanted to adopt or adapt it, I think that could be done. But illness management and recovery is still focused largely on illness management. The recovery part was added at the end, and it doesn't really have as broad a vision of the life of the community living with, being in recovery with an illness or with a mental illness or mental health condition, as perhaps RAP would be. So you might also take a look at what else is available. There's also pathways to recovery developed by Priscilla Ridgway and her colleagues in Kansas, which is also available via the net, and that might be another alternative. There's actually a curriculum for training facilitators of pathways to recovery available through Focus on Recovery United in Connecticut.
Chris has asked a question. The VA has discussed the idea of peer drift. Have you come across anything in the literature that adequately discusses this concept of peer drift?
Peer drift? What does that mean? Is that what he said?
Yeah, Christopher, I'm going to need you to take and elaborate a little bit more on what peer drift is, please.
If what Christopher means is drifting from the original vision of peer support, that's sort of the point I was trying to make in my talk, is yes, there has been peer drift, if that's what it means. And there are an increasing number of articles coming out now concerned about the role, integrity of peers and how to preserve the pureness of it. So it is a concern, and we need to, that's the vigilant part. We need to be vigilant about that.
Okay, and yes, you were answering the right question according to Christopher. Boy, these questions are coming in so fast I can't even keep up with them. Are there any challenges if peers are not paid at all if they volunteer their peer experience and volunteer their time?
That's a very popular...
I'm sorry, go ahead, Larry.
It's a very popular approach in the addiction recovery world, the 12-step approach and the idea of giving back. If somebody in recovery with a mental health condition wants to do that, I think it's fine and wonderful. You just don't want to get exploited. And if you can get paid for it, why not?
Barry, I'm not sure I understand your question. Money, how could peer support get fiscal support, i.e. drug companies, profit, prison, DLGCT, lobby against peer support? Barry, I'm not sure I understand your question. You're going to have to clarify it a little bit for me. I'm sorry.
While you're looking, I'll just say that forensic peer support or peer support provided to persons in the criminal justice system is a growing field. I would be reluctant to accept money from pharmaceutical companies just because of the history, but
I have a question from Sheila. Sheila's asking, what are some of the other job titles or job descriptions of peer supporters? Rita, feel free to chime in anytime you want here, too, please.
Well, the VA calls them technicians, I think.
Yeah, I think they do call them technicians.
The people are called peer specialists. Some people are called recovery specialists. Some people are called recovery coaches. There's lots of different language.
Yeah, I've heard the term peer coaching, recovery coaching. There's all kinds of terms that are out there. Rita, are you on the call?
Yeah, I'm here, Peter. Sorry, I was just hosting the quiz, so I needed to do that. So,
Okay, I'm sorry. And what I needed you to do was to go over with the group how they can access the PowerPoint and how they can access the certification.
yep, no problem.
Thank you so much.
Sure. You'll see on the slide that's up that says receive a certificate of participation. Go to the I.N.A.P.S website. On the homepage of the I.N.A.P.S website, in the right-hand column, there is a link that goes to a quiz. It's a quiz with 5 questions, and it also asks you to put in your contact information so that you can have a certificate mailed, not email, mailed to you, postal mail. And you'll get it in about 3 to 4 weeks when we complete the quiz. We just need to have records of who has taken the webinar and who is wanting to apply for continuing education with their certification body. So that's why we do this. So
Now, is there also a way if a person isn't interested in the certificate, which I wouldn't understand why they would do that, but wants a copy of the PowerPoint, how can they do that?
They still have to take the quiz because we really try to keep the quiz available without the PowerPoint, so people have actually attended the webinar, take the quiz, and then they get credit for it. If we just post the slides, then people can take the quiz off the slides, and that's just not fair to the people that have been here. So we don't post the actual PowerPoint until about 3 weeks after the session. But you do get access to it if you take the quiz.
Okay, I hope that's clear to everybody.
Even if you fail, you get access.
Yep.
Has anybody failed?
That was a joke. That was meant to be a little humor. That was a little humor.
Little humor. Andy Bernstein, is there a platform? Boy, this thing is moving so fast. Is there a platform for? Oh, folks, I can't read this fast. You got the stuff coming in so fast. Is there a platform for interstate sharing of progress towards peer and family-provided service inclusion in Medicaid and Medicare to the integrated health care?
There is I.N.A.P.S, which is probably the best resource. The other one to think about in terms of integrated health care is the SAMHSA Center for Integrated Health Solutions. And Larry Fricks is a vice president there and very knowledgeable about the peer role in integrated health care. You can contact him.
Okay, Barry has tried to clarify his question again. What I was trying to say, that it seems that why we are supporting peers, others like drug industry and profit prison are lobbying against peer support. So what he's basically saying is that there are systems that are taking and lobbying against the expansion of peer support. I'm gathering that's what he's saying, Larry. So do you have any comment to that?
I have not run into any people who have been lobbying against peer support. I must say I've been astounded that even the people who promoted the Murphy bill from Pennsylvania that is pushing for outpatient, involuntary outpatient commitment still allows that peer support is a new and important resource that should be enhanced. So I've not run into any organized opposition. Maybe people know to stay away from me, but I haven't seen it myself. And as I mentioned before, prisons are starting to hire peer staff, and even the forensic hospital, the maximum security forensic hospital in Connecticut is now training people inside the prison to be providing peer support. So I haven't seen that.
All right, Pat from Illinois. A question was asked: Are there any challenges to peers working as volunteers? I have seen mental health agencies in Illinois who want to change the culture of their center. They started internships in their recovery services program, who are trained by peers who work there now. After internships, the agency hires the interns. They have been able to go from 3 peers to 6 peers in the past 3 years. That comes from Pat from Illinois. And I don't know if you got an answer to this one, Brett, Larry, or not. Brett asked the question, I'm curious if anyone has heard of or experienced any peer support in the corporate world. I can touch upon that a little bit from the Optum perspective that I have, and that's we've recently launched peer support groups in the commercial world, in the commercial insurance world, not the public sector world.
Wow.
And it's going fairly well so far.
That's great.
Yes.
I know there is interest. I think Australia or New Zealand are both just had some kind of legislation about mental health in the corporate world, and there's more interest at the highest levels of the World Bank and places like that of understanding that depression is a major barrier to productivity. So there may be opportunities for more and more peer support in the corporate world. That would be very exciting. In terms of volunteering, I would just say that I'm a big believer in choice and that people should have choices. And one choice that some people might value is the choice to volunteer when they don't feel like they're ready for, up to, or interested in paid employment. So let 1,000 flowers bloom, or whatever that saying is.
Okay. I would. My Lord, I can't keep up with all these. Is it possible to provide questions and comments and Dr. Davidson do a follow-up web to address them after he has read them? I don't know that we can do that one, Deborah. That's reaching a little bit. But what we are trying to do is get to as many of the questions as we possibly can. We are at a point where we only have 3 more minutes left. So if there's a question that you specifically want to answer, please ask that question right now if you would. Okay. Peer support specialists own and operate their own business providing services.
Yes.
Peer support, yeah. Peer support specialists own and operate their own business providing services.
Yeah.
Do you have any comment to that?
Absolutely. I get questions now fairly regularly about is private sector peer support available? Can I hire a peer supporter to outreach to my son or daughter? And I think that's a great idea.
I do too. So, Seal McKinney has asked, what is the boundary between peer support and peer counseling? And counseling. She didn't say peer counseling, I'm sorry.
Peer staff should do what they're trained to do. They should be counselors unless they've been trained to be counselors, and I'm not sure. You can be a counselor without being a peer. I'm not aware of any formal integration of peer counseling in mental health, per se. It's done a lot in schools, but I'm not aware of that having been done in terms of mental health care. I don't think
I've seen it work in the community health worker field. Some community health workers have also been peers. But you know what? There's peers that are social workers also, and there's peers that are psychiatrists, and there's peers that are psychologists. So, yeah, there's peers in every area that we infiltrate, so, which I think is a good thing.
Yeah, it's just be important about the role. That's all. Thanks, Fred.
Okay. So you're keeping up with the chat questions here, too. Rita, what else am I supposed to do in terms of... Oh, I guess that's it. Good. I was going to check to make sure that I'm doing what I'm supposed to do. I am a contractor, certified peer specialist. Well, thank you, DMHAS. I appreciate it. Lots of comments, Larry, about this being a great presentation and what a great job that you have done.
Thank you so much.
I can't thank you enough for the information, the valuable information that you put forward to our peer supporters and to our attendees. And I want to thank you for that very much. I know how busy your day is, and for you to take time out of your day and do this, I certainly appreciate it.
Oh, it's been my pleasure. Keep up with the great work you guys are doing.
All right, listen, everybody, take care. Have a good day, and thank you all very, very much for participation. Take care, everybody.
Bye.
Bye.